Dear student, in my previous videos, I explained about the stretch reflex and the inverse stretch reflex. And I told you in those videos that these two concepts will help us to explain some clinical conditions like clonus and clasp knife rigidity. So in this video, we will explain why clonus is a feature of upper motor neuron disease or lesion. Now, what is clonus? Clonus is a regular, rhythmic, alternate contraction and relaxation of a hypertonic muscle. And when it will happen? It will happen to a sudden and sustained stretch. Here we can see the ankle clonus. You can see here it is initiated by brisk dorsiflexion. So it is first the foot is dorsiflexed and this dorsiflexion is maintained. In response to these, what we can see, we see the rhythmic plantar flexion at the ankle. So first is the dorsiflexion, brisk dorsiflexion, that is maintained, and followed by that there will be rhythmic plantar flexion. Now it is said that it is in case of clonus, there will be increased gamma motor neuron activity. Now we want to know the physiological basis of this clonus. Alternate stretch reflex and inverse stretch reflex, it forms the basis of clonus. So physiologically we need to explain it how this alternate stretch and inverse stretch reflex is causing clonus. Now one point is clear that the muscles on which we are testing it, it is hypertonic. Why? Due to upper motor neuron lesion. So the patient is having upper motor neuron lesion and this is causing muscle hypertonia. Now in this hypertonic muscle, if we stretch it, so we know the effect of stretch, there will be muscle contraction as a result of stretch within a physiological limit. The muscle contraction is the stretch reflex. Now if this stretch is maintained, okay, now if it is maintained, then the muscle, the next reaction of the muscle is relaxation via inverse stretch reflex. And the same sequence is maintained as long as the stretch is offered to the muscle. We know what is stretch reflex. We are stretching the muscle and this is the cause and the effect is the strong contraction of the muscle. And we also know about the inverse stretch reflex. So here, when this stretching is going beyond the physiological limit, the response is not contraction, it is relaxation. Now what are the components of this inverse stretch reflex? We know all reflexes, they have 5 components: receptor, afferent nerve, central relay station, efferent nerve and the effector organ. In case of inverse stretch reflex, the receptor is the Golgi tendon organ which sends the response of tension, information of tension to the central nervous system via the sensory nerve 1B, and there will be relay at the central nervous system and there will be muscle which is actually the impulse that is coming from will undergo relaxation, whereas the antagonist muscle will undergo contraction. So this was the inverse stretch reflex when stretch is given beyond the physiological limit. Now in these hypertonic muscles of upper motor neuron paralysis, muscles are already hypertonic. So when you are causing stretch, there will be contraction, and if this stretch is maintained, this contraction will be higher. So tension will be greater, and this greater tension will be conveyed by this Golgi tendon organ to the central nervous system, and the inverse stretch reflex will be stimulated. So stretch reflex will be followed by relaxation of muscle or the inverse stretch reflex. And alternate stretch reflex and inverse stretch reflex forms the basis of Clonus, and it is found in upper motor neuron lesion. So in case of Clonus, there will be more gamma discharge, but one point is important, that it can also happen without involving the Golgi tendon organ. So how it can happen then? It is due to the synchronized motor neuron discharge. So at this anterior horn cell, we know several motor neurons are there. Now the muscle spindle, it is hyperactive. So they release the burst of impulses and activate all the motor neurons at once. So these bursting impulses will cause muscle contraction, and we know that if the muscle is contracted, two Z lines are coming together. So what will happen to it? So we know that if these two Z lines are coming closer, so this muscle spindle will be relaxed. It will be laxed. But if stretch is maintained, then this laxity is prevented, and there will be discharge will be from the spindles. The stretch is maintained, and the stretched muscle, the muscle spindle will remain stimulated, and that will cause the burst of impulses at the anterior motor horn cell, and there will be firing of all the motor neurons synchronously at a single point of time. Now we know that Clonus is regular, rhythmic, alternate contraction and relaxation of hypertonic muscle, and when to a sudden and sustained stretch. What are the causes of Clonus? In which pathological conditions it can happen? It can happen in traumatic brain injury, brain tumors, strokes, multiple sclerosis, spinal cord injury, amyotrophic lateral sclerosis, multiple sclerosis, epilepsy, liver or kidney failure. But we want to specifically address the Clonus, occurrence of Clonus in spinal cord injury, where the descending cortical tract is disrupted. Now the Clonus in spinal cord injury, what happens? Spinal cord injury means there will be disruption of the descending cortical input. The commands which are carried from the cortex, which are carried by this descending cortical tract, they are disrupted. Okay. Now, at the spinal cord, we have some glycinergic inhibitory interneurons. So this black one you can see. So these neurons are known as the Renshaw cells. So what is the function of this Renshaw cell? So this red one is the alpha motor neuron. So it helps in the contraction motor neuron. So when this motor neuron is excited, it is carrying the excitatory impulse. What it does, it gives a small collateral to this Renshaw cell. And what is the function of Renshaw cell? Its function is inhibitory. It will in turn inhibit the same alpha motor neuron. So it will actually act as a negative feedback mechanism. So this is the Renshaw cell. This is the alpha motor neuron. It is carrying the positive impulse. While carrying, it is giving a tweak to this Renshaw cell. So Renshaw cell is inhibiting it. Okay. So in this way, the hyperactivity of these alpha motor neurons, it is controlled. Okay. So this is the function of the Renshaw cell. Now Renshaw cells are getting excitatory input from this alpha motor neuron. Okay. Anything else Any other tract are also sending inputs to this Renshaw cell. Now these Renshaw cells, okay, they are also getting inputs from the cortical descending fibers. What happens during the ankle clonus? We can see that ankle flexions, the cortical fibers activating the ankle flexion, they synapse on these Renshaw cells. That Renshaw cells, as well as they also synapse with the 1A type of inhibitory interneurons. Okay. Now we know that when there is any kind of flexion or flexion of the muscle, the antagonistic extensor muscle should be relaxed. If there is contraction of flexions, there must be a simultaneous relaxation of extensor so that the movement of the muscle, it becomes smooth. Okay, so now this descending cortical fibers, they synapse with the activating ankle flexures, as well as they also form synapse with the 1A inhibitory interneurons, which are actually causing the relaxation of the extensor muscles. Now what happens if the cortical fibers are disrupted? What will happen? When these cortical fibers are damaged, these 1A inhibitory interneurons, they are not inhibited. So the antagonistic muscles, the inhibition on the antagonistic muscles, it will persist. Okay. So we know that when the flexures are active, there will be simultaneous relaxation of this. But in case of disruption of the spinal cord, in case of spinal cord injury, this inhibition on this antagonistic muscle, it is absent. So what will be the result of it? There will be repetitive sequential contraction of ankle flexures as well as ankle extensors. So this is also a cause of clonus in upper motor neuron palsy. Regarding the treatment of the clonus, often centers on its underlying cause should be treated. For some individuals, physical therapy that includes stretching exercise can reduce the episodes of clonus. Immunosuppressants like azathioprine, corticosteroids, anticonvulsant, tranquilizers are beneficial in the treatment of clonus. Botulinum toxin has also been used to block the release of acetylcholine in the muscle, which triggers the rhythmic muscle contraction that are characteristics of clonus. Thank you. So I think this video can explain that why clonus is a feature of the upper motor neuron lesion. One is the alternate stretch reflex and the inverse stretch reflex, and in case of spinal cord injury due to the withdrawal of the inhibition on the antagonistic extensors, there will be simultaneous flexures and extension contractions. So this is my reference. Subscribe to the channel. Thank you.